morning. I'm Dr. Sean Coomer, Chief Medical Officer of the Kansas City Division of the University of Kansas Health System. Welcome back to Open Mics. When you live in a rural community, cancer can come with extra costs. You have to fill up the gas tank just to drive to see the right specialist. You might need to pay for a hotel. And if there's no place close by that offers cancer screenings, it's harder to detect cancer early. Today, we're exploring some ideas to improve rural cancer care. We're also meeting a young man who just graduated medical school a few days ago, and he's already making a difference for cancer patients in rural America. Alexis Del Cid explains this young physician learned invaluable lessons after a stage 3 melanoma diagnosis.
I had been kind of feeling this thing popping out of my neck, and so I sent a picture to a friend who was an oncologist here in Wichita, and I was like, hey, I have this coming out of my neck too, and he was like, okay, that's not good.
Doctors told Zach Schrader he would need treatment at a cancer center more than 500 miles away from his home in Independence, Kansas.
My family spent over $8,500 on just travel and lodging, none of that covered by insurance.
After radiation, surgery, immunotherapy, and almost 5 years of clear scans, Zach will soon be able to say he's in remission. But now, he's on a mission.
Between heart disease and cancer, those are the two leading causes of death. And to tell people that they have to travel this distance to get treatment for these things, I think is tremendously wrong. If you look at the mortality rates for urban and rural, they're both decreasing just because science, surgery, and everything is getting better. However, there's a gap between urban and rural falls behind. And there's always been a gap since 1999. But the problem is the gap is widening.
Zach co-founded the Rural Cancer Institute, dedicated to closing that gap. When he's not meeting with lawmakers, he's trying to normalize the idea of keeping oncology care closer to home.
A lot of people are just naive to it, even people in healthcare. I tell oh, I want to do rural oncology. Like, is that a thing?
He co-authored a recently published article in the New England Journal of Medicine Catalyst, proposing a new model of decentralized cancer care.
We get a local patient with a local provider, a general oncologist, and then we leverage telehealth with specialists in urban areas, or maybe they go see the specialist 1 time or 2 times in the urban area, and then they get to do the majority of their treatment close to home.
Changing the status quo is always a challenge, but Zach's experience and optimism keep him going.
When I tell somebody, hey, I want to be a rural oncologist, and then they say, no, you can't do that. It's good that I'm probably too strong in my will sometime, in my ways, that I'm oh, yes, I can.
Zach, or should I say, brand new Dr. Schrader, congratulations on your graduation from the KU School of Medicine in Wichita. Where are you going for residency?
Thank you. It's great to be here. I'm going to Wake Forest in Winston-Salem, North Carolina. Go Demon Deacons.
Go Deeks. I know a little bit about that place. Congratulations. That's fantastic.
Thank you.
We're also joined by 2 expert oncologists, 1 medical and 1 surgical. Dr. Gary Doolittle is a melanoma specialist at the University of Kansas Cancer Center and medical director of the Masonic Cancer Alliance. Dr. Kelsey Larson is a breast surgical oncologist at the Cancer Center, as well as the state chair of the American College of Surgeons Committee on Cancer. Thank you both for being here.
Happy to be here.
Thank you.
Zach, you were diagnosed with stage 3 melanoma on your 21st birthday. Not exactly what you expected on your 21st birthday, I'm sure. We're glad you're doing well, but is it fair to say, use the word remission?
Yeah, actually just last week I had my last trip to MD Anderson for my 5-year follow-up scans, and everything came back great, and so it is safe to say I'm in remission. So it's with graduation, remission, it's been an exciting week in the Schrader household.
Yeah, congratulations, that's fantastic news on both accounts. But you had to relocate for your cancer treatment. How did going back to someplace other than your home impact your treatment?
Yeah, thankfully I had my brother who lived down in Houston, so I was able to stay with them. But there's just something about the comfort of your own home to return to whenever you're sick, and I just didn't have that luxury. And so I'm thankful for the people that and my support system down there. but it was tremendously tough to go back to somewhere that was foreign to me whenever I was at both a low emotionally, physically, and mentally. And so it was tremendous. It was a tremendously tough year, but it was one that set me up for a lifetime of change, I think.
Yeah, it's nice that you had family. Was that a big brother or a little brother?
It was my oldest brother. I'm actually the youngest by quite a bit. So my oldest brother took a tremendous care of me throughout my cancer journey.
Okay, he didn't beat you up growing up, did he?
He did that too. I think he felt like he had to help me on the back end. He had a lot of debt to pay.
Yeah, exactly. Good. I'm glad he felt a little guilty. But your experience led you to co-found the Rural Cancer Institute. Who else was involved in creating that, and how did you get it started?
Yeah, so I went to the NRHA, or the National Rural Health Association conference 3 years ago now, and there was a presentation over rural oncology. And with my experience, I was like, wow, these are the two things I love, rural medicine and oncology. And so it was a presentation given by Dr. Wade Swenson, who's a rural oncologist in Staples, Minnesota. And after the talk, I reached out to him and I was like, hey, I really enjoyed your talk. This is something that I'm tremendously passionate about and interested in, and told him a little bit about my story. And so we had a meeting over Teams, kind of like we're doing right now. And he said, hey, there was an ASCO task force dedicated to the rural cancer gap. But since COVID and a lot of other things, it kind of fell apart. And so there's nobody advocating or doing research in this gap. And so that's where we started the Rural Cancer Institute. So it was with Dr. Wade Swenson and then Dr. Emily McGovern and then Dr. Swenson's daughter as well, Abby. And so now we're spread across, I think it's probably 20 states or so with about 50 to 60 individuals. And we actually just got announced, I think it was South Carolina, announced Rural Cancer Awareness Day. And so I think we're up to 8 or 9 states now that have proclaimed that as Rural Cancer Awareness Day. So in just 3 years' time, we've grown and come a long way. It's been great.
Oh, that's fantastic. That's a tremendous initiative. But the rural-urban healthcare disparity is not limited to just cancer, and there's been great progress made in closing some of those gaps. The health system is part of the CARE Collaborative, which partners with rural hospitals to improve common medical conditions, including heart attack, stroke, sepsis, and outcomes. Dr. Doolittle, besides geography and access to health care, fewer big employers mean less insurance. How do all these barriers impact the rural patients that you treated over the years?
Yeah, that's a good question. It is a challenge to deliver health care in the rural sector, even if you're a generalist. And part of our challenge in the state of Kansas is not only do we have rural areas that aren't covered adequately for oncology care, we also have a lot of health provider shortage areas that aren't even covered adequately for primary care. So you put that together with employers that don't offer health insurance, or a state like Kansas that didn't expand Medicaid, you're really struggling economically to get your health care, and that's for primary care. You struggle even more so for cancer care. And then you're piling on travel and the burden of us being away from home, as Zach just clearly pointed out to us. So it's a challenge, and there are people out there doing great work, but we need to help them, and we need to continue to build and improve upon that.
Mm-hmm. Yeah, we certainly have some medical care deserts out there, that's for sure.
Absolutely.
Dr. Larson, what worries you most about cancer patients navigating the disease and treatment in smaller communities?
Yeah. So there's some very good literature from breast cancer, which is my specialty area, that says when patients travel to a tertiary center, about 43% of the time their treatment plans change as a result of the new information that we can gather or we can offer. So I think the biggest challenge is, how do we identify the 57% that can get great care at home and don't need to travel, versus how do we identify the people who have a change in treatment that really would benefit? And that's a question we haven't quite figured out how to distinguish from yet.
Mm-hmm. And even with that change in treatment, if we offer added expertise, they can still go home and get some of that locally. Just it's that added opinion from a subspecialist that may change the treatment plan and improve outcomes.
Mm-hmm. Yeah, absolutely. There are challenges that patients face, but on the flip side, what challenges present for physicians who have cancer patients that live hours and miles away?
Want me to jump in, Kelsey?
Well, I was going to say, I would guess that we have different challenges. I mean, surgery is a hands-on, in-the-moment thing, right? I can't do remote surgery on someone. We haven't quite cracked that code yet. I'm sure it's coming. And so probably some of our things are the same. About a quarter of my practice is telehealth, so I can see a lot and do a lot in follow-up and advice. I can't operate remotely. And so there's different barriers, I think, for different specialties.
Right, and in the medical oncology world, so many of the agents that we give are associated with side effects and different toxicities. And if you give a particularly worrisome or an agent that can result in toxicities, you're sending them 4 hours away if that actually happens. And the worry about managing and close follow-up is a challenge. And that's where telehealth has been a great tool, because we can actually conduct toxicity health interviews with a patient in their own home, even if they're a 4, 5, 6 hour distance away.
Yeah. As you mentioned, Dr. Doolittle, it's so specialized and subspecialized in cancer care. So, Dr. Larson, you treat breast cancer and only breast cancer. I know you also do some other benign breast cancer or breast disease as well. And Dr. Doolittle, you treat skin cancer and only skin cancer, but in a rural setting. Zach, you'd like to see more generalized oncology care. What would that look like in your thought?
Yeah, so we kind of outlined this in our New England Journal of Medicine Catalyst paper, talking about how we pair a general oncologist with their patient and then leverage telehealth with physicians in urban centers like Dr. Doolittle to really give that team-based work and the best care close to home. And so right now, kind of the status quo is pushing people to super subspecialty and cancer care. However, my dream is to be a general oncologist taking care of a wide-based patient network. And so I think that looks like taking care of the colorectal cancer to the skin cancer. But like I said, leveraging telehealth with specialists to make sure that we're all on the same plan. And I think that is one of the keys to making sure that we keep care close to home, because I don't know of anybody else really in Southeast Kansas that has had skin cancer like mine. So to be able to support a super subspecialist oncologist is just not likely. But the general oncologist is something that I think the population there can support. The rural population is just getting older and sicker, and cancer diagnoses are just increasing. And so the patient population is there. I just worked on a paper that I'm currently working on that I hope to have published later this year. In urban areas, the patient to provider ratio is about 80-1 for new invasive cancer rates. However, in rural areas, that ratio is 500-1. I think with that, there's kind of two messages in that there is a lack of oncologists and a lack of healthcare providers. But there's also just a lack of oncology in rural areas. And I think Kansas actually does a great job in meeting the needs for rural patients. But at the Rural Cancer Institute, we're a national organization. And so I think Kansas is almost, especially the university and the health system, is kind of a pillar of what we should see across the country as well, with the Masonic Cancer Alliance, and then the start of a new oncology fellowship of the community or rural side. And so that's kind of a first of its kind to my understanding. And so I think Kansas is really leading the way. And so at the Rural Cancer Institute, we're kind of taking what Kansas is doing and showing what they can do as well to really close the gap in states other than Kansas as well.
Right. We mentioned a little bit about telehealth and earlier, and Dr. Doolittle, you have called yourself a telehealth zealot. I know early on in telehealth, before we kind of got going with COVID, I remember going to that room down the hall from the ED and how primitive it was in some ways compared to now. So I know you basically built that, so thank you. But what made you so passionate about telehealth, and how can it help in rural cancer care?
Right. A lot of it actually comes from my personal experience. I had lost several members from my immediate family in the first couple of years that I was a faculty member. And they were all in an urban setting. I was available, they had resources, and it was still a huge challenge to get their cancer care. And then you couple that with understanding that there's, if you get west of Topeka, so many of our counties in Kansas are frontier. Their population density is 6 persons per square mile or less. So even though the need is there, the distribution of oncologists is just really unbalanced, as Zach just clearly pointed out. We have enough in Kansas City. We probably have enough oncologists in the state. It's where they're located. Telemedicine enabled us to reach out to the furthest areas in the state to provide expertise for the local healthcare team to actually deliver the care. Kansas was actually ahead of the curve on that. In the 90s, the state legislature invested in a telecom infrastructure that allowed us to harness the technology and provide care at a distance. But you can imagine the difference in the technology in the 90s compared to where we are in 2025. I mean, you can provide a consult for a patient in Southwest Kansas by pulling over the road on I-70 and connecting them, with your iPhone. So the technology's really enabled it. It's a lot less expensive, and then I think culturally we accept it a lot more. COVID did help us with that. If there was anything positive that came out of COVID, it was the understanding that we can harness the technology to see patients in the comfort of their homes, or to see patients that are connected with a local healthcare provider in the office setting or in the emergency room setting.
Yeah.
So,
I think we all have stories about our patients and where they've been when you've had a consult with them. I've often had to tell my patients to please pull over while they're driving, and so we can have the visit.
I had one visit where a patient was driving down I-70, and the whole time I'm like, I want to get off the phone with you. I cannot continue this. So it's real.
Yeah, well, it is. Yeah, absolutely. And there's some worse stories than that, for sure. Dr. Larson, when do your cancer patients need to come to a bigger cancer center? And can you do breast cancer care via telehealth? I think you said a little bit about that before.
Some aspects I think you definitely can. Surgery is one thing that's hands-on. I can't operate remotely. In the acute post-operative time, as people are healing, if they're having any complications, any issues, that's a hands-on thing. Similar with radiation oncology, that is have to be in person, on site for those type of treatments. As Dr. Doolittle mentioned, there are medications that can be higher risk for complications, gets people a little nervous when folks are traveling. But let's think about the patients that are doing their 5-year pill, their hormone blocking pills. Those are reasonably tolerated, and it's just checking up, seeing how symptoms are, yearly screening mammograms. Things like that definitely can be telehealth. So I think Zach's idea and Zach's suggestion is really very appropriate, which is to distinguish, do we have to do an all or nothing, right? It doesn't have to be all rural and all urban, but let's try to work together and to develop that network so that we can say, hey, here you really got to come, but Zach's going to be your medical oncologist and he's going to do a great job locally for you once you're healed up from surgery. That's the ideal.
Great. Can you also tell us a little bit about your work with the American College of Surgeons and specifically the Rural Cancer Accreditation in the works? What is your hope that happens with that?
Yeah. So the American College of Surgeons, COC, is basically an opportunity for hospitals and health systems to have an outline for what is excellent quality of cancer care. And with this outline, there are different levels. So somewhere like KU Cancer Center would have, a higher level of accreditation and different standards because we're doing research clinical trials. Somewhere like a smaller town or a smaller community would have the expectation that they might not have everything on site, but they would have a network of people they could reach out to. And so the rural accreditation is a brand new thing that's going to be rolling out in the coming weeks and coming months. And the idea is really to formalize that network where rural cancer providers actually have those outreach and those touch points. So essentially it's similar to what MCA does, but it's run through the American College of Surgeons. And it's based on great work that's been done, really started out in Kentucky with the McCann Cancer Institute, some great work also in Iowa and North Carolina that's happening. That's really a framework for how this is going to roll out to the rest of the country.
Yeah, well, great work. More to come. That's fantastic. To get more care to more patients.
Yeah.
We're here to answer your questions. Please send them in using the links on your screen, YouTube, Facebook, or email the Medical News Network. Let's check in with Doc Hop. Leaders at the FDA have detailed their plan to change COVID vaccine recommendations. Instead of recommending shots for everyone 6 months and up, they want to limit the vaccines the most at risk and create new clinical trials for healthy adults. Who would be eligible for COVID shots under this new plan, Doc Hawk?
Yeah, that is the plan, and the anticipated recommendation is that instead of just everybody 6 months and over is eligible for a vaccine or recommended for a COVID updated vaccine, it will be those at highest risk who are 6 months and up, so those with chronic conditions, which could be lung conditions, heart conditions, obviously cancer, asthma, those types of things, which would put those younger people at risk. But then it will likely be recommended for everybody 65 and over. So these are the anticipated changes. Now we should note that many other countries also do this risk stratification and have recommendations for mostly age-based of 65 or 75 and over recommended to get it. So we'll see how this does play out and how it changes. I would just like to say, however, obviously, you know, I've stated on this show that I'm not too worried about my children getting COVID. They've had the vaccine. They should be fine, but we should also recognize and understand that the vaccines also, there is good data to support the fact that they help reduce the risk of long COVID. And so that's really more the main impetus why I have given my children the vaccine the last couple of years, so that they can reduce their risk of long COVID. So we'll see how it ultimately plays out. I think we should be aware of those things as well, those secondary outcomes that may be improved, but we will wait for the final recommendations. But it is expected to be more of a recommendation for those 65 and older, and then if you are younger than that, if you have chronic comorbid conditions that put you at greater risk of severe disease, there will be a recommendation for that, as opposed to the current recommendation, which is really everybody 6 months and over.
So COVID's still out there. We definitely have patients every day in the hospital with COVID. It's definitely been attenuated from our peak several years back, but it's still real. So anyway, thanks for that advice.
Absolutely.
Let's switch gears to measles. You saw a new study trying to quantify how many lives are saved by the MMR vaccine and compared to other childhood vaccines. It sounds like it's a lot.
Oh yeah, absolutely. So we know that we have eliminated measles from the United States for local and spread in the United States since 2000. You know, in 2019 we did have an increase in cases, but now we are seeing continued local spread in our communities, again, most notably in Texas and New Mexico. We've had local spread here in Kansas as well. But we should say that the measles, mumps, rubella vaccine has proven and shown to be a very effective and safe vaccine for preventing illness and preventing death. There was a new study out that showed that in the course of 50 years from 1974 to 2024, it actually saved 93 million lives. So that is vitally important. Again, eliminated from the United States in 2000, but we have to remember all the other places around the world as well. It was only very less available in other countries, especially in the African continent, in other resource-poor communities, really from 1980 to 2000. Although it was available, it was certainly not as available as it was here. But then really in 2000, became more widely available, and we had seen such a decrease in the amount of cases, but also deaths. So, I mean, I think the main point is, again, over the last 50 years, we've seen really saving lives of 93 million people, and I think that is vitally important. We need to continue to endorse the use of this very safe, very effective vaccine for preventing the disease, but also the complications, including death.
Yeah, and you mentioned, you know, it was declared eradicated from the United States in 2000, and then maybe you know, some people decided not to get that, and then exposures happen. I think that's what we're seeing here now, right?
Yeah, absolutely. And when we have that 95% herd immunity or population immunity, we're able to stop the spread and the transmission of this disease because the vast majority of people are vaccinated and protected. But that is not what we have seen currently, just as you have stated. So we have more and more people who are at risk of getting the disease because they are not protected. And so that is what we are seeing now in our local communities, not just in New Mexico, Texas, Kansas, but now other places in the United States as well. So we really want to try to get back to that 95% herd or population immunity to really stop the spread, so there isn't that susceptible person who then can get the disease, obviously have risk of the complications, but also spread it to others as well.
One more question for you. Yeah. So, you know, many of us had the MMR vaccine when we were younger. And there are some people that it sort of loses its efficacy. Who are the people that should be getting titers drawn to see if they need to be revaccinated?
Yeah, that's a good question. So right now the CDC recommends that anyone who was born 1957 or before is considered immune because of just the virus was circulating so much at that time. Most people were probably exposed. Otherwise, if you have had 2 doses of vaccine, you are considered immune. Now, there was that little gray area of people from about 1957 to about 1965 or 67, where it was a different type of vaccine, but also there was also probably 1 dose recommended. It wasn't until later until 2 doses were recommended. It is vitally important to try and get your vaccine records to see if you've had 2 doses of vaccine. If there is a question, it is going to be safe to revaccinate or to get a dose of MMR. Now, you can draw titers as well to see, and these are antibody titers to look at immunity. We should note that sometimes the test is not as sensitive, so you may have immunity even if that titer is low. But I think it is worth a conversation to your physician or to your medical team about that, and then consideration of either just getting a dose of MMR to fulfill that 2-dose recommendation, or drawing those titers to see if there is evidence of immunity from either previous vaccination or less likely actual infection.
Thanks, Dr. Hawkinson.
Yeah.
Appreciate it. We know many of you have some questions out there, so let's head to Studio B with the honorary Dr. Alexis Del Cid.
I like that. Thanks, Dr. Coomer. We have a great question from Stuart. Stuart writes, a lot of rural hospitals are already struggling financially, so how can they afford to add oncology services?
You know, I think that's a really good question, and part of our concern in Kansas is that we have not expanded Medicaid. And then when we have the national dialogue about possibly cutting Medicaid dollars, that's a real worry because our rural hospitals really depend upon that to just stay open and to stay viable. The question that's oncology specific is a very germane one because a lot of these drugs are extremely expensive. There's a time lag when the hospital is reimbursed, and it can be a real struggle. I think one of Zach's model to have regional centers that can take that on and that can take that risk is probably one of the best ways to handle the financial uncertainty when you're delivering this type of care. Having said that, for patients that have insurance that reimburses well, you can counter some of the other challenges that we have. And it can actually be a positive thing for a rural hospital to be able to deliver oncology care and bill for those services and keep that revenue close to home.
Mm-hmm. Yeah, I mean, I think that you made a very good point. People think that we get paid at the time of service and it's delayed significantly. But the insurance or not, so you have to eat that for a while until you get more stable.
Exactly.
Jeremy Yenser has a really interesting question. Jeremy writes, do you see less participation in clinical trials from rural areas? Are they less likely to be selected or approved for the trials due to distance?
Yeah, again, a very good question. And that's one of the reasons we started the Masonic Cancer Alliance, which is the outreach network for the KU Cancer Center. And one of its early primary functions was to support access to clinical trials in the rural sector. We know as a patient base, if you go on a clinical trial, the kinds of statistics that Zach is worried about, meaning rural cancer patients don't do as well as urban cancer patients with care. We know if you have access to clinical trials and you go on a clinical trial, your care is every bit as good locally. Part of our mission at the KU Cancer Center and by extension the Masonic Cancer Alliance is to get clinical trials close to home. We have 7 different sites in the state now. We're building, there's more coming, and the goal is to make sure everyone has access to a trial. This is standard of care in the oncology community. This isn't something new or edgy. Every cancer patient should have access. Whether they choose to participate is an individual decision, but having access and knowing that you can try something new and different, particularly for those patients that have a cancer that to date is considered, quote, incurable. Mm-hmm. What do you think, Zach? I mean, I know you're concerned about cancer care and clinical trials. What's your thinking?
Yeah, I think like you said, the clinical trials are kind of the standard of care when it comes to treatment. And so I think it's the Masonic Cancer Alliance is doing a great job. I think they're building a new mobile unit as well. And so I think that's a great modality to meet the needs of rural patients as well. But yeah, we need to decentralize clinical trials to be able to get more and more of those clinical trials to rural areas. And like you spoke on earlier, the toxicities are what you're really worrying about. And so how do we monitor those toxicities closer to home? PCORI actually has a grant out right now that I think could be a catalyst for that, to be able to monitor those symptoms and those toxicities closer to home. And so I think we're moving in the right direction.
Question from Jill. Jill has a question about internet service because she shares that the small town she came from didn't have broadband. So is internet service a barrier in some communities?
I think internet service can be a barrier in some communities. You know, the good thing now is with a lot of the changes that happened in COVID, we are able to offer telehealth via phone too. It's just a simple documentation that just says video was not available due to internet connectivity or patient preference or things like that. So that has opened up some opportunity where at least if folks have some sort of phone service that we can connect with them. Certainly it depends on what we're using it for. So again, for a post-op patient where I might need to see an incision to see how it's looking or how it's doing, we might have to get creative about at least emailing a photo or sending a MyChart of a photo, but there are creative workarounds we can use.
I do think it's a good point about the internet issue, and one thing we can always fall back on, if we can't connect with the patient in their individual home, we can connect with them at their local healthcare facility. They usually have broadband access, and that's not an issue. I don't think it's optimal necessarily. I would love to have the option to get to everyone's home, but it doesn't mean we can't still provide services from a distance. Just we want to work with that local healthcare community. And again, my bias in the telehealth space is, I'm providing information, I hope, that will benefit the patient, but I have to be working with the people on the ground in that community. So if a patient if we can't access from their home, we can still be working with the people on the ground. The future docs in the rural sector like Zach, connecting with them in their office if we can't catch them in their own home.
Yeah, absolutely. This has been a great discussion. I'm grateful to our guests for being here. I want to get some final thoughts before we go. We'll start with Dr. Larson.
Yeah, I am really excited, I think, for the future of rural cancer care. The fact that rurality is recognized as a barrier, just like some other barriers to care, is really important. And I think a lot of the groundwork we're seeing, as Zach outlined, and as Dr. Doolittle has shared with us, is kind of a really positive step forward. So I think the future is going to be wonderful if we keep going in this trajectory.
Dr. Doolittle?
Yeah, I would echo some of those thoughts. I'm actually proud of the medical community in the state of Kansas and the work they provide right now. That doesn't mean we don't want to be better next year, and whether that's supporting local primary care practices or whether it's supporting oncologists that are generalists in the state. I'm proud of what we do now, but I want to stretch further and be better next year. And by the time Zach comes back and does his community oncology fellowship with us, he'll be heading out to rural Kansas as well. That's a promise, right, Zach?
Yeah. Well, we'll see. But that's the plan right now. But we'll see. There's a lot of time between now and then, I think. So there's a lot of decisions to come down the pipeline.
Yeah. Well, that's a perfect segue. So, any final thoughts that you have, Dr. Schrader?
I just want to say thank you for having me on today to talk about something I'm so passionate about. At the Rural Cancer Institute, we have our conference June 6th and 7th, and I just want to say thank you to Dr. Doolittle for being there and being our keynote speaker. And then Dr. Doolittle today is actually wearing on his lapel is wearing our rural cancer ribbon, and so that's specific for rural cancer patients. No matter what the cancer is, there's, like we've talked about, barriers are unique to rural patients, and so that's why we created that ribbon to show that. So thank you all for having me on. This has been a great experience, and thank you to all of KU for having me for the past 4 years as well.
Yeah, thanks for being on. My final thoughts are, we have 3 people on here that are passionate about rural care. Our University of Kansas Health System, as well as the University Medical Center, is very passionate about rural care and has made an initiative of that house-wide. So we're all about trying to get rid of medical care deserts. And that's very important for all our patients throughout the state and beyond. So thanks again to all of our guests and our audience. We'll see you next time.
I'm Alexis Del Cid. On the next All Things Heart, we've shown you the life-saving benefits of lipoprotein apheresis for people with high cholesterol, like this little girl. Now see how the treatment is helping pregnant moms. Why this mom says it's the reason she has her miracle baby in her arms. Thursday at 8 a.m.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.